Ooh, E-volley or e-cigarette is the e-cigarette or vaping use associated lung injury. E-volley. E-volley. So this is a whole new arena of pneumonia that's come up since vapes have become so prevalent in society. So other names for these e-cigarettes are vaping or mods, ends or vape pens. They can have nicotine, THC oils, CBD oils, flavors, additives, vitamin E, all of these different things that are irritants to our lungs. And so what ends up happening is, people will push a button and it'll ignite a battery that will heat a heating coil that will heat these liquids into a vapor that you puff and inhale into your lungs. Now, when these first came out, there was no regulation of the vapes, of the e-cigarettes. So people could say that there's 1 milligram of nicotine when they really had 5 milligrams. But now that there is, I believe it's the Food and Drug Administration that is monitoring and regulating the e-cigarettes, it's a little bit more in control. But what's crazy is we're seeing this in our youth. We're seeing this in teens, and we just need to make sure that we're keeping these things out of teens' hands because their lungs still haven't fully developed yet. Their brains fully haven't developed yet, and we're allowing the youth to inhale these toxins, and we just need to make sure that we are on top of this because there is dangers and there is hazards that are associated with vaping. Some of those hazards are bronchitis, bronchiolitis, acute hypoxic respiratory distress, and lipoid-associated pneumonia, pneumonitis. There's even deaths that have been associated with vaping, and that's getting close to 100 deaths, confirmed deaths that are associated with vaping. And even with those flavors and those additives, we're seeing that even old diseases like popcorn lung that we had eradicated are starting to come back because vendors are using these flavors of oils that are popcorn flavored, and we're seeing popcorn lung pop up again. And it's just crazy to see that we get rid of something and the world finds another way to bring it back and be prevalent. But anyhow, characteristics: patients have to have a history of using e-cigarettes or vapes of some sort. They'll have a cough, they'll have chest pain, they'll have tightness in their chest, they'll be short of breath, nausea, vomiting, diarrhea, they'll have fever, chills, you may even see weight loss. Like I said, there are upwards of 100 deaths that are associated specific to vaping. So we just need to make sure that we're doing all that we can to educate those around us of the dangers of vaping. Some of the more nasty pneumonias. So we've got necrotizing pneumonia and even abscesses. So this is talking about lung gangrene. This causes death to the lung tissue, and it seriously eats the lung tissue away. So you no longer have like lung tissue for gas exchange. So oxygen's not getting in and carbon dioxide is not being removed. It leads to fluid-filled cavities and collecting purulent exudate. So purulent is another form for pus. It's another name for pus. So you have purulent exudate with this necrotizing pneumonia and abscesses. So with these, you can see that you have this really nasty, tenacious, green, foul sputum that starts to fill all of the lung interstitium and the alveolar epithelium. So what ends up happening is the pulmonary capillaries, they'll dilate, the interstitium will fill with fluid, and that will lead to swelling of the alveolar epithelium, and then that fluid has to spill over into some area, and that area is going to be the alveoli. Alveoli is going to back it up into the airways, and you get this really nasty secretion, those distal airways. So with pneumonia, you end up seeing structural changes. You have alveolar consolidation, you have tissue and wall destruction, tissue necrosis. You can have some cavity formation, the fibrosis and calcification. You can end up with bronchopleural fistulas, empyemas, which is an infection in the pleural space, atelectasis, and an excessive amount of secretions. So these are like the pathophysiology of what's happening. So when you have a patient that has moderate to mild pneumonia, that's going to start to impact their ability for gas exchange. So oxygen is not going to be coming into the blood, and carbon dioxide is not going to be eliminated in those areas. So you end up with a diffusion problem, leading to a dead space problem. So when you have a mild or a moderate pneumonia, it'll lead to a respiratory alkalosis with hypoxemia. So when their oxygen levels fall, when your oxygen level goes down, when you're hypoxemic, our physiologic response is to breathe more and beat more. So when you breathe more, when I breathe faster, I start to eliminate more CO2, right? So when I eliminate CO2, that increases the pH. So early on with a mild or a moderate pneumonia, your ABG will show that you have a respiratory alkalosis with hypoxemia. When you start to get to a severe pneumonia and you don't have the ability or the means to maintain oxygenation anymore, you're going to have a severe hypoxemia, and at some point that tachypnea or that breathe more that you've been doing to maintain your oxygenation is going to give up. Like at some point, unless you're David Goggins, you have the mental fortitude to keep breathing the way that he can run 100 miles with shin splints that are the worst. But you'll end up with a respiratory acidosis. So these patients no longer can keep up with the hypoxemia. Their body will start to give up, and that CO2 will start to climb, and you go from impending ventilatory failure to acute ventilatory failure with a severe hypoxemia. So depending on how bad that pneumonia is, if it's mild or moderate, then your ABG will look like a respiratory alkalosis with some hypoxemia. If it's severe or they've been hypoxemic for an extended period of time, they will go into a respiratory acidosis, and we'll definitely need to intervene with some sort of non-invasive or invasive mechanical ventilation. So when we look at the PFT values, all of your volumes are going to be decreased. This is a restrictive disorder. All of your volumes are going to be decreased. When you look at your flows, you're going to have normal flows. This is not going to create massive obstructions in your flows. When you look at your chest x-rays, you're going to have increased opacities and increased densities. You're going to see some air bronchograms that can lead to pleural effusions or an empyema. So be on the lookout with your chest x-rays. When we look at treating our patients, you want to make sure that you're treating your patients with the right whether it's antibiotic, antifungal, or antiviral. Get them the right treatment depending on whether it's a viral, fungal, or bacterial infection. The patient's going to need fluids. They're going to need to make sure that they stay hydrated. You're going to need to put that patient on oxygen. They're going to need to maintain their diaphragm, because they're going to want to lay around in bed and not want to do a whole lot. And when that happens, that diaphragm starts to sneak up higher, higher, and higher, and that can lead to atelectasis. So we want to make sure that those patients are up, walking around, and keeping that diaphragm as low as they possibly can, and assisting with any sort of airway clearance therapy. So CPT, mucolytics, IVP, any of those will lead. Any of your vibratory or PEP devices is what we're going to want to do to treat these patients. So that is our first, disease that we're going through. Pneumonia is a very hefty disease or condition that patients are struggling with. And like I said, it's the 8th leading cause of death in America, and it's things that we can do to take care of these patients. So identify these things early, get these patients on the right treatment plan so they can get discharged.